lovely humans, welcome back to the channel and today's video, which is all about autosomal dominant polycystic kidney disease. This was a session that I recently delivered live at my local hospital to BPT studying for their written exam, and I figure if I'm sharing it there, why not share it with you guys as well. And if you are studying for your exams, then be sure to click the link below to claim your free souvenir from this tutorial. It's a one-page summary of everything we're covering in this session for revision in a jiffy. I hope this helps your studies. Now let's jump right in. Welcome guys. So I'm actually really excited to be here. As you can tell, I love talking about the kidney. And today we're going to be talking about autosomal dominant polycystic kidney disease. And I've really tried to make this quite relevant for your BPT exams, things that might come up for MCQs. So for those of you who don't know me, my name is Christine Barker. I'm a nephrologist and medical educator. And of course I work here at Alfred Health. So too much fun. So what do we expect today? We're going to go through some PKD pearls for MCQ success. I think you're going to find this fairly high yield. There's going to be some interaction because I want you to stay with me and absorb all the learning. So for the 4 of you who are on, I hope you're into that. And at the end, I'm going to give you all a souvenir. It's a one-page summary of everything that we are talking about today, so that closer to exam time, it just takes you 5 minutes to revise everything we're about to discover today. So why is polycystic kidney disease important, and why might it show up in your written exam? Well, the reason for this is that in Australia, PKD is actually the 4th leading cause of end-stage renal failure, and it is a pretty prevalent condition in the population. So the prevalence is rated anywhere between 1 in 400 to 1 in 1,000, depending on whether you're looking at genetics or people who have phenotypical expression of the disease. So over to you, and I'm really happy. You don't have to unmute if you don't want to, but I mean, I would love it if you did. But you could put things in the chat box if that makes you feel more comfortable. But I did want to gauge from yourselves, do you know any genes that are involved in ADPKD? Because this can come up in MCQs. And do you know how genetics affect the phenotype? So in terms of the genes, of course, it's autosomal dominant polycystic kidney disease, so no points for knowing that it's an autosomal dominant inheritance. But what does that actually mean? It means that we have both males and females affected, and also if you have polycystic kidney disease, then you have a 50% chance of passing that gene on to your children, boy or girl. So the most common genetic mutation affects the PKD1 gene, which codes for polycystin 1, and that's coded for on chromosome 16. So this is the most common type of mutation, but it's also unfortunately the most severe. So these patients tend to have larger kidneys and earlier end-stage renal failure. So typically having end-stage renal failure in your 40s and 50s rather than your 60s and 70s. The worst mutation to have is a truncating PKD1 mutation, which means that you've got genetic material that's missing, deleted, that type of thing. As opposed to a missense mutation, where you've got a few amino acids out of whack, but you still got a lot of the genetic material there. So a truncating or deletion type mutation would be the worst one to have. 15% of people have a mutation in the PKD2 gene, which codes for polycystin 2, and that's located on chromosome 4 and has a milder phenotype than PKD1. So some of these patients might develop end-stage renal failure in their 70s, for example, and some just never need dialysis at all. And 5% would fall into the other category, lots of small print genetic mutations that we don't need to worry ourselves with today. So these patients have a good gene and a bad gene. They don't have 2 bad genes, and so there's no true recessive form of this condition. So basically, if you had 2 bad genes, it would be incompatible with life. And I just want to point that out to you because there is another condition called autosomal recessive polycystic kidney disease. That is a different condition with a different genetic makeup, and it's actually predominantly a liver disease. So I just want to make that distinction. These people have 1 good gene, 1 bad gene, but 2 bad genes would be incompatible with life. And in terms of that phenotypic variation, so I asked you that question before, and I guess it's really important to realise that when someone with polycystic kidney disease is in front of you,
their destiny is not determined by their genes necessarily. There are a whole host of other factors that can come into play. So just because someone's gran or their mum or whatever was on dialysis by age 40, say, that does not mean that this person is destined for the same fate. Actually, there's a real phenotypic variation despite having the same genetic mutation. So it's a very individual journey. Now, we're saying that these genetic mutations are in genes which code for polycystins, but what on earth is a polycystin? So polycystins are these glycoproteins that are expressed in numerous tissues throughout the body, so kidney, bile ducts, vascular smooth muscle, bronchial epithelium, to name a few. And they seem to be important for the function of primary cilia. So they can be located on the cell membrane or on the endoplasmic reticulum. And polycystin 1 and polycystin 2 tend to be co-located and work together. They're usually co-located next to something called a primary cilia, and so cystic kidney disease can also be called a ciliopathy. Now, when I think of cilia, I think of the cilia inside my lungs, right, that's helping to clear mucus and things like that. But we also have these things called primary cilia, which are present on cells throughout the body, the whole body. And what they're basically doing is they're acting as a little antenna. They're looking outside the cell and taking information into the cell regarding things like mechanical stress, for example, and that will change the signaling inside the cell. And so we don't know how this all perfectly works, but what we do know is that the polycystins sit next to these primary cilia, and they function to help that primary cilia in some way and affect the intracellular signaling. And they also function as a calcium channel. Now, in the chat box, if you all are listening, which part of the kidney do cysts originate from? The glomerulus, the interstitium, or the tubules? Hazard a guess. There are more people here now. Hi, team. Tubules. Yes, it is the tubules. Perfect. Thank you for talking to me. It's going to be so much more fun if you talk to me. All right, so yes, it does affect the tubules. So coming back to that pathophysiology and connecting it all together, to make a cyst, we need a couple of things. We need to put fluid into the cyst, but we also need the cell proliferation so the cyst can grow over time around that fluid in the cyst. And a really important molecule for this is cyclic AMP. So cyclic AMP can promote fluid secretion and cell proliferation. And another key thing is calcium. Now, I told you before that the polycystins can act as a calcium channel and they can influence the amount of calcium in the cell. And this in turn can affect cyclic AMP and reduce the breakdown of cyclic AMP, meaning there's more cyclic AMP around. It can also, in its own right, affect the cell turnover and cell replication. So that can also cause cell proliferation. So that's how these polycystin mutations or abnormalities can promote cyst growth. But of course, that's a complete oversimplification. There's about 3 million different pathways that are contributing to this. But this is the one you need to know to help you understand what I'm going to say for the rest of the talk. And there are a few other key contributors. Vasopressin can increase cyclic AMP, and we'll come back to that in a bit more detail shortly. And other growth factors around the body can also contribute to this process. So in terms of how we get from this genetic mutation to disease, if you think about a little baby in utero and it's got the genes for polycystic kidney disease, it has about 2 million nephrons, and all of them have the exact same genetic material. They have a copy of the good gene and a copy of the bad gene. It's all the same. But their tubules look normal, right? Because they have the good gene and it's working. But 5% of those little nephrons will undergo another hit, a second hit, another genetic mutation, which means that they'll lose their good gene, right? So it's only happening in 5%, but in that 5%, those tubular cells will develop cysts. Over time, those cysts will grow, and over many, many years throughout that person's life, they will develop polycystic kidney disease. But wait a minute, if only 5% of the nephrons are affected, how does this lead to end-stage renal failure? basically, even though there's a lot of healthy nephrons around still, these cysts, as they grow, as they start to push on the healthy nephrons. So over time, as those cysts get bigger and bigger, they're going to cause damage to the surrounding nephrons, and they can do this in a number of ways. So the first way is obstruction. So if you can imagine that you've got a cyst and you've got lots of little draining glomeruli and tubules, sorry, not glomeruli, nephrons. I do love glomeruli. Nephrons, and they've got all these little tubules and they're coming from the cortex into the medulla, and there's thousands of them, right, on that microscopic level. And you put a cyst in the middle of all that, you could potentially obstruct thousands and thousands of nephrons with each cyst, right? And when a nephron is blocked and obstructed, it's becoming damaged, right? That's just how it is. So it will drop off, it will get damaged. The other ways that cysts can cause damage to surrounds is by impacting the blood vessels and lymphatics. So it will stretch the blood vessels and make the blood vessel think that there's ischemia. So then you'll get an increase in the renin-angiotensin-aldosterone system, you'll get hypertension, and that can damage kidneys as well. You can also get distortion of the anatomical structures like the loop of Henle, which means that they can't concentrate their urine quite as well. And urine concentration deficits and hypertension are some of the first earliest signs of PKD in a young adult. And then because of all this pushing and shoving and all the damage that's happening, you get this extra tubulo-interstitial inflammation. The immune system starts to come in and try and figure out what's going on. And ultimately, you get nephron loss from that, but also the healthy nephrons that are left behind are working harder, right? Because you're going to have nephron dropout, and then the ones that are there are working harder, and eventually they're going to drop off as well just by becoming exhausted. So that's all the ways that having those cysts can lead to end-stage renal failure or renal impairment at least. And this is a really important concept for MCQs. This kind of thing can come up, so I really want you to lock this in. So having lots of cysts causes your kidneys to be enlarged, and so big kidneys are a risk factor for end-stage renal failure. And the total kidney volume is associated with a decline in GFR. That's really important. And we use this in some of the classification as I guess, systems that we have. The most famous one is the Mayo classification, and they use MRI scans to put people into these categories. But you can see here that the lowest risk would be the smallest kidneys over time. They're probably never going to need dialysis, but these ones with the bigger kidneys, they're very high risk of developing end-stage renal failure at a fairly young age. We can use other scores. Now, I don't want you to internalize this, but just to tell you that there's another way that we can assess severity of polycystic kidney disease using genetic testings and various phenotype aspects, like how many urological complications they've had and at what age, that type of thing. So just to let you know, there are more than one scoring system, but you don't have to really know that in detail. So coming on to the diagnosis, a patient appears in an MCQ or clinic room near you, and they have an ultrasound which shows renal cysts, and their GP has referred them because of this. How do you approach this? How do you rule in or rule out ADPKD? Just looking for some ideas. Yes, ask about family history. That is beautiful, Emily. Thank you so much. Yep. Any other ideas? Nope, that's okay. Do not worry. All the answers. Oh, genetic testing. Good thought. Yes, good thought. We don't use that very often, but I mean, technically you could if you knew what gene. The thing with genetic testing, because I haven't really touched on this in the talk, but with genetic testing, there are so many mutations that probably the best way to do genetic testing is if you do know about an affected family member, you know what their mutation is. But I believe that you can test, you can do a broad screen on someone that's got a sporadic mutation, but we don't do it very often, for sure. And then particular imaging findings. Yes, love your work. And here we are. If positive family history, you don't need as many cysts to diagnose. Yes. Oh, you guys are good at this. Okay, let's check out these slides to back up basically what you're saying. So if you have someone in front of you who has a family history of ADPKD, then it's pretty straightforward, and it's just age, what's their age, what's the number of cysts, and then you just basically Google this little table and it'll tell you all the answers. So basically, if you're 15 to 39, you need 3 or more cysts in total. 40 to 59, you need 2 cysts in each kidney or more. And if you're above 60, then 4 or more cysts in each kidney is essential. If you're looking to sort of rule out PKD in someone, autosomal dominant PKD in someone, then if they're above 40 and they don't have, they've got less than 2 cysts, you could pretty much say that they're probably just run-of-the-mill cysts, nothing to worry about. So you can exclude the disease in that situation. If they're under 40, it's a bit less clear because, of course, the cyst that they have, it's possible that they just have a smaller, they have lots of cysts, but they're just very small and they're not being picked up by the ultrasound at this stage, but give it a few, decades and they could sort of manifest. So if you really need to rule out the diagnosis of PKD in someone who's less than 40, then you can do an MRI because that shows really, really small cysts, and then you can do that count. Like you mentioned, you could do genetic testing. We don't often, but it's possible. Or you can just observe that person for a bit longer with those uncertainties. So it probably depends on their ambitions around family planning and things like that. So you'd go through the usual route of considering getting a geneticist involved to have those discussions. So in terms of if someone had no family history, or maybe they're adopted, they don't know their family history, or they're just saying, nah, like no one in my family has ever had cysts, but they've got quite a few cysts on that ultrasound, then the imaging findings can be helpful. So a couple of clues is the fact that they would have large kidneys, because other types of cysts, often the kidneys are normal sized, there's cysts in them, but the actual kidneys themselves are normal size, whereas polycystic kidneys fairly uniquely create these big, large kidneys. Having bilateral cysts is also, I guess, a supportive feature. Now, you do get some scenarios where you get mosaicism of genetics, so one kidney is affected whilst the other's not, but that's quite unusual. So usually polycystic kidney disease, the genes are in all the nephrons, it's going to affect both sides. And the cysts are present in both the cortex and the medulla, so it doesn't discriminate, it just goes anywhere in the kidney, it feels like. And there are more cysts than would be expected for age, and I'll show you on the next slide what would be expected for age. So as we go through life, we can get like acquired cysts that can be quite normal in the population. So for those above 70, it's quite common to have at least one cyst, over 20% have that. Bilateral, 9%. If you're 50 to 70, then again, having one cyst, not that unusual, and bilateral, a bit less commonly, but still, doesn't really mean much. And then 30 to 49, it's quite unusual. You sort of less than 2% have a cyst, and bilateral cysts, 1% of people have. So maybe in this age group, when you're less than 50, it can be helpful, but in these older age groups, I don't know, depends how many cysts there are. I'm sure it gets a bit dicey and borderline. But I'd say in your MCQs, it's going to be pretty obvious, and they'll probably have a family history or so. So in terms of the renal manifestations, we've touched on a couple of these. So we talked about how the kidney can get damaged by those cysts, and you can get renal impairment, you can get albuminuria because of that nephron stress and nephron dropout, and you can get hypertension because they get CKD, but also because of that stretch of the blood vessels that makes the kidney think it's hypoxic, renin-angiotensin ramps up, and they get high blood pressure. You can also get hematuria for various reasons, so that can be microscopic or macroscopic. And some of the common reasons for this include a ruptured cyst. So that's usually macroscopic and pretty dramatic, hematuria, but also, of course, infection, stones, and also malignancy. So it's not necessarily the case that polycystic kidney patients get malignancy and RCC. It's not the highest risk. Intuitively, you'd think that they might have malignant transformation, but it's not as common as you would think. But in someone who has polycystic kidney disease, what I just want you to be alert to is the fact that you do need to think about those things still, right? So just because they've got blood in their urine and they've got polycystic kidney disease, you wouldn't just put it down to that. You would do due diligence and you would look for mitotic processes. So you would image their upper tracts, and you would also think about doing cystoscopies and things like that, all the usual things you would do, rule out infection. So just to not be blinded by the fact that they have cystic kidneys, just think about all the things. And in terms of UTIs, they can get infected cysts. So of course, UTIs start in the bladder and then climb up into the kidney. And if they infect a cyst, it can be really troublesome. So some of the cysts are still in contact with the urine. They're kind of like a little outpouching from the tubule, and the urine's still in contact. So sometimes the usual antibiotics we use for UTIs can penetrate the cyst, but sometimes the cyst is kind of removed from the tubule. It's not in contact with the urine, and so in that sense sometimes we have to use lipid soluble antibiotics. Most commonly ciprofloxacin would be used to really get into the cyst, and these patients can have flank pain and pressure effects. So they've obviously got big organs that are so much bigger than they should be. They're pushing on all different parts of them and they can feel just pain, non-specific pain that can be quite severe. They can also have reduced appetite because they just, there's just a lot in there and they just feel early satiety. So that can be troublesome for nutrition and things down the track. Now, extrarenal manifestations, we said before that these polycysins are in lots of different tissue beds, right? So it's not a surprise that this is like a multi-system disease to some extent, and there'll be different phenotypes and different proportions of people who'll be affected in different tissues. But some of the common things that come up in the heart, people with polycystic kidney disease are more predisposed to mitral valve prolapse, for example. But you have to remember as well for your MCQs that people with CKD and end-stage renal failure that might be due to polycystic kidney disease or something else, they all have an increased cardiovascular risk. So it just depends on how the question's being posed at you. They could be trying to get to the fact that they've just got, a high cardiovascular risk. So just be careful when you're reading the stem not to jump to conclusions there. With the liver, you can have a polycystic liver as well as polycystic kidneys. And something, I don't think this would come up in an MCQ, but just really to be aware for your own personal practice, because it's not commonly, I guess, known and described, is that polycystic livers are quite sensitive to the effect of female hormones, so estrogen and progesterone. So if you're a female with cysts in your liver, then they grow fairly rapidly in the reproductive years, and then it can slow down when you're post-menopause. But it could be aggravated by, giving someone hormones with the oral contraceptive pill or with hormone replacement therapy, HRT, in menopause. So just to be alert to that, not to prescribe female hormones to patients with polycystic kidney disease without really counselling them on that. Really try to avoid it. And of course, something you're probably very familiar with is intracranial aneurysms. So my question for you, who should be screened for intracranial aneurysms? Any ideas? Who would you screen for intracranial aneurysms? Would you screen everybody or just a select few? Oh, the silence. The silence. Okay, I'll give you the answer. I'm having the best time. I hope you're having the best time behind those screens. In terms of screening for intracranial aneurysms, you don't screen everyone. That's the key message here. We don't screen everyone. And there's a few reasons for that. So around 8% of people with polycystic kidney disease will have an intracranial aneurysm, and their risk is 5 times higher than the general population. And of course, if they did have a ruptured aneurysm, then that comes with a 50% mortality rate. So it's very serious. But most commonly, even when they do have an aneurysm, it's less than 7 millimeters, and it's in the anterior circulation, which in the general population has a fairly low risk of rupture. And the risk of rupture in PKD patients is about the same as the general population. So we don't overdo the screening because it can cause a lot of angst, and we don't want to interfere with aneurysms that would otherwise have not been complicated and actually maybe cause some complications in the process. So the people we screen for intracranial aneurysms are those with a family history, or those with a personal history, so they've previously had an intracranial hemorrhage, or they have a neurological presentation. So a polycystic kidney disease person comes with a headache or some neurological problem, you're going to scan them for an aneurysm. So yeah, have a low threshold in those scenarios. People with high-risk professions like pilots or bus drivers, we're going to take real care. And sometimes before elective surgery, because at the time of a general anaesthetic, we have these swings in our blood pressure that could pop an aneurysm. But especially we do this for if we're considering transplant, because of course, not only do you want to protect them from that perioperative risk, with the anaesthetic and the risk of aneurysm rupture, you also want to make sure that you're taking a kidney and putting it into them. You want to make sure that they can benefit from that resource, right? And of course, you get live kidneys versus deceased donor kidneys. Both are precious, but could you just imagine the scenario where you have a live donor and then this person ends up having an intracranial event? It's just an absolute disaster. So it's not very evidence-based necessarily, but I'd say that most centres will scan their polycystic kidney disease patients before they'll list them for transplant, before they'll consider doing a transplant. You might also think about this when it comes to risk-benefit of anticoagulation. So being on anticoagulation doesn't increase your risk of a rupture, but if you did rupture, of course, it's going to be worse. So just making sure that you're weighing that up with yourself and the patient. And when we do want to screen, we use MRI or MR angiogram to detect aneurysms, and that does not require gadolinium, so you can use that in very advanced CKD. And we much prefer that to using a CT angiogram when the GFR is low, obviously. And we don't tend to treat aneurysms that are less than 7 millimeters, and we follow up with repeat MRIs depending on the size and stability. So I would tend to defer that decision making to our neurosurgical colleagues in terms of following that up, obviously. But yeah, so that's the sort of guidelines. And if you have decided you want to screen someone that they fall into this category, but then they don't have aneurysms, it's proper or appropriate to reconsider that in 5 years, to go back to the drawing board and think, well, do we need to rescan them if they still fall into these categories? And screening family members for PKD in general, not for aneurysms, but just for the disease. In terms of children, we don't tend to screen children. We would tend to wait till they're 18 and above and then let them decide. And the screening test would be an ultrasound initially, and then further genetic counselling, depending on, I guess some people who have polycystic kidney disease, they come from families that have very sad stories in them, and they might be very motivated to know. They might be very motivated not to pass the gene on because they've seen a lot of, they've had a lot of loss, they've had a lot of trauma watching their family members go through things. So it's a very individual thing, and it can be quite harrowing for family members. So that's the diagnosis all sorted. Now, what about the management of ADPKD? Do you have any ideas about that? Tovapton. Any other ideas? Do you treat everyone with Tovapton? What else do we do? Oh yes, the RAS inhibition. You guys are all over it. Okay, let's explore this. So in terms of, I mean, this is really the answer to most things CKD related. We've got like a general management strategy, which includes our PKD patients. So of course, all the usual lifestyle things apply, including blood pressure, attention to lipids, making sure they're a healthy weight, all that jazz. Obesity actually does increase the growth of cysts. So that's something extra to be aware of. We recommend a low salt diet. And we recommend hydrating really well and aiming for a urine osmolarity of less than 300 milliosmoles per litre. Now, that probably won't come up in your exams because there's been some negative studies which looked at, prescribing water versus just letting them hydrate how they want to and all of that. But as a general principle, it's not going to do them any harm to hydrate well. And I guess what I'd say is my personal practice is, and we'll come back to this later, if they're well hydrated, they're going to have less vasopressin in their system, and that will hopefully help them over a longer period. I think being dehydrated is probably not something we'd recommend for a PKD patient. So that'll all make sense in just a tick, but it's not necessarily supported by trials or anything. We mentioned avoiding the hormonal contraceptives in female patients because of those liver cysts, and consider screening for intracranial aneurysms in the right person. But you did mention Tovapton. So Tovapton is oral medication. It's taken twice a day. Usually patients take it first thing in the morning, like 6 or 7, and then 8 hours later, just so that they're not taking it close to bedtime, so that they're not up all night peeing. It's a very expensive drug, but it's available on the PBS. So I don't know how you would do this in the chat box, but you might just give me the salient points. How does Tovapton work? Or you can unmute and tell me all about it. Yes, it counteracts vasopressin. Yes, it does. Oh, here we go. This is great. This is wonderful. It's all going to be reinforced. Yes, it's a V2 receptor antagonist, which means that it blocks vasopressin in the nephron. So let's unpack that for the MCQ win. So vasopressin, also known as antidiuretic hormone, this is the normal physiology. So we've got dehydration or increased osmolarity of our serum. Our pituitary gland is going to make vasopressin. That's going to go to the kidney and act on this V2 receptor. That will increase cyclic AMP, which in turn will place aquaporins into the collecting ducts so that we can reabsorb more water back into the body. So that's how that works. But coming back to this diagram to show you how this is relevant in PKD, we said that in order to make a cyst, you need fluid secretion and tubular cell proliferation. And cyclic AMP also promotes those two things. And vasopressin promotes cyclic AMP. So vasopressin goes there to put the water channels, the aquaporins, into the collecting duct, but as a side effect, it's also increasing the cellular signaling that promotes cyst growth, cyst formation. And when they did animal studies, what they found was in the sort of rat study where they had the right genetic setup, when they actually injected them with vasopressin, it promoted cyst growth in those rodent models. And they found that people with ADPKD actually have higher levels of vasopressin in their circulation compared to the general population. So vasopressin, was where it was at. We were thinking that's what we need to target, and that's why Tovapton was invented. Like I say, there are lots and lots of other pathways. This is not the only pathway, but it's the only one we have a treatment for right now. So that mechanism of action again, Tovapton is a V2 receptor antagonist blocking vasopressin in the collecting duct. That's where it acts. So Tovapton is affecting the cell signaling, which may or may not, which I'll come back to in a second, may or may not slow cyst growth. The jury's out on that, but it may or may not do this. But what it does do is it has a very predictable side effect in basically all patients that you prescribe it to. Can anyone tell me what that side effect is? Because that would be a great MCQ, I reckon. As you can tell, my goal is to have you all set up for all the MCQs. What would be the main side effect of Tovapton? Diuresis. Yes, diuresis, the aquaretic effects. Now, I'm going to walk through this just because past me, who was sitting my exam after a full day of clinical work, would have found that a wee bit hard. You probably find it easy, but I'm just going to go through it so it's all very, 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 very clear. So just recapping on that normal physiology, feeling thirsty, increased vasopressin. Vasopressin increases aquaporins and we reabsorb water. So our urine is very concentrated. There's not a lot of water in there, but there's lots and lots of solute. So we have concentrated urine with a high osmolarity. When we give Tovapton, we're going to block that vasopressin effect. We're going to have less aquaporins there, so we can't absorb as much water. So we're going to lose water in the urine, and we're going to have very pale, dilute urine with a low osmolarity. So I'm just throwing that to you because MCQs come up in different ways. They'll talk about osmolarities and bits and bobs. So I just want you to have that kind of down so you don't get thrown off. So as you mentioned, yes, the main side effect of Tovapton that you'll see is polyuria, polydipsia. And whilst this really happens in all of the patients that you prescribe it to, that they'll pass a lot of urine, about 8% of people just cannot tolerate it for this reason. So obviously 92% are doing just fine and they're managing this just with hydration, but 8% of people just cannot and have to stop the drug. Now, it might surprise you that only 4% of trial patients had hypernatremia. So all that water spilling into your urine, of course, you'd think there'd be a risk of having high sodium, right? But actually, that was not the case. And it's not the case because these patients are told to drink lots of water. So if they're passing 5 or 7 litres of urine per day, they're supposed to be drinking that much water, and they're all counselled to do that. So they're getting ahead of it. We actually teach them to not drink to thirst, but just to drink before they're thirsty. So it's just constant. So it's a real lifestyle adjustment. But yeah, passing 5, 7, sometimes more than that litres per day is a pretty big ask, but they don't tend to become hypernatremic. That would only be a risk if they didn't have access to water. The other thing to be aware of is the potential liver dysfunction. So in the original trials, about 4 to 5% of patients had significant derangements in their LFTs. And because they weren't sort of tuned into that, they weren't monitoring it quite as frequently. And some patients were very close to, liver failure. It was that bad. Then they cut back on the drug and it got better. But what they tell us if we're prescribing this drug is that we're supposed to do monthly LFTs and for the first 18 months. And then after that, we do 3 monthly for the duration of the drug. The other thing that was quite a common side effect was gout. Now, this wasn't sort of nasty tophaceous gout. This was a kind of a run-of-the-mill, here and there, bits and bobs gout, which was easily handled with the usual remedies. So it wasn't something that made people come off the drug, but it was one of the more common side effects. Also, just being aware of Tovapton drug interactions. So you're not going to be prescribing diuretics with Tovapton because of that side effect, right? Because you don't want them to pass any more urine than they already do. So that would be one of the main things. And it also is impacted by CYP3A4 inhibitors, which I've listed there. I'm sure you're sort of across that with your pharmacology MCQs. But now I'm going to go into the evidence base for Tovapton, just in case this was to come up. But I don't know. I'm not sure if you need it or you don't need it, but I'll take you through the trials, because the actual trials themselves, we tried to read them. I found they took me hours to get my head around. So I'm going to give you my sort of take on the trials. Obviously, if you want to read them, go for your life. So the evidence base for Tovapton started with this trial, the Tempo 3-4 trial. So it was a placebo-controlled trial, multi-centre, randomised, double-blind, and they followed these patients up for 3 years, and there was more than 1,000 patients in the trials. Participants were fairly young and they had excellent renal function, and they had big kidneys, right? That was the sort of, because they thought at the time that big kidneys were the marker of all badness. So good kidney function, but big kidneys. And the primary outcome was the annual rate of change in total kidney volume, because again, they're chasing this concept of volume as a marker of severity. And what you can see here is that Tovapton did slightly better than placebo in terms of slowing the rate of growth, but most of that impact was in the first year, and then it sort of leveled off. They had these secondary outcomes, which basically suggested that maybe Tovapton reduced the rate of decline in GFR, but it was all hypothesis generating. It wasn't powered for that. And they also found that patients on Tovapton had less kidney pain than the placebo patients. So then what they did from there was that they extended that study to the Tempo 4-4 study. So now you had an early group who were originally on Tovapton and a delayed group who were originally on placebo and now they're on Tovapton. So now everyone's taken Tovapton. 60% of those patients stayed in the trial and kept going, and they had an open label trial and 2 years of follow-up. And the primary outcome here was the maintenance of change in the total kidney volume in early and delayed subjects. So basically, over this whole 5-year period where we had some people start it early, some people start it late, I think they were hoping that they would show that if you started it early, that you would do better. But actually, it was a negative study. And by that sort of the end of the study, everyone was really at the same point. So it was a negative study. But in their secondary outcomes, when they were looking at GFRs, they found that both of these groups, whether they started early or late, were having this sort of slowing down of decline in GFR on Tovapton. So they needed to do something which had GFR as a primary outcome. So they designed this other trial called the Reprise study, which was a placebo-controlled trial, so Tovapton versus placebo, again, multi-centre, randomised, double-blind, over 1,000 people, but only 1 year of follow-up this time, which is pretty short for a big trial, right? They had a range of ages and a range of GFRs. So now they're looking at people who had, advanced CKD down to CKD 4, as well as those earlier groups. And they only included people if they could tolerate the drug this time. So the 8% of people who can't tolerate the drug were excluded, and everyone else who could handle the drug were included and randomized. And ultimately, this is what they found. So with Tovapton, this thing happens the same as ACE inhibitors or SGLT2 inhibitors. You'll be familiar with how when you start those drugs, there's about a 20% drop in GFR. And that's the same as Tovapton. So you go on to Tovapton, you have a potential 20% drop in GFR, and that is acceptable, and just a sign that the drug is working. And then it comes back up. If you stop the drug, like at the end of this study, you'll see that it just pops right back up, and that's because of that just sort of background impact on GFR. And so what they found was that Tovapton did seem to slow the decline in GFR in this 1 year, right? So they weren't sort of looking at many, many years, in this 1 year. And then what they did was they extrapolated that data from the other trials. So I won't go through this again, but Tempo 3, Tempo 4, they had these secondary outcomes with the GFR suggestive. Then they did this thing about the GFR, and they only did this for 1 year. So what they then did was they went and took the trends from those previous other trials and kind of included it here as a projection. So I say that to you just to say that we don't have like a mega long follow-up of these patients that says that this reduction in GFR is maintained, but they've extrapolated from the other studies, which was a different patient group and all the things. So there's a bit of statistical juju that I just want to tell you about. But ultimately, if this is true, if Tovapton slows the GFR decline more than placebo, then this is what we can expect from Tovapton. So say, for example, you have a patient who has a GFR of 60. To get to a GFR of 15 where they need dialysis, if their kidney function is declining at 5 mils per minute per year, so you do some maths and you figure out that in 9 years, they're going to be on dialysis if they keep up this rate. So with Tovapton, we could potentially, if the drug does what the statistical juju says that it does, that person might not be on dialysis at 9 years, but might be on dialysis at 12 years. So you, by being on a drug for 12 years, you buy yourself 3 years off dialysis. That's what the drug is supposed to do. And most patients would say that that's worth it to them. But just, I guess, making sure that we're aware that those side effects of having all that polyuria, polydipsia, all of that is happening for 12 years, to stay off dialysis for 3 years. So all that to say that taking Tovapton in the long run, the goal is to delay end-stage renal failure by a few years, but life's got to be worth living with those side effects as well. And it's not like we have that long data that you can really say to a patient, this is absolutely the case for them as an individual. You just have to hope that it is true. And there's other patients who would never end up, on dialysis. Those polycystic kidney, so PKD2 mutations, I told you they were a more gentle phenotype. You don't want to put them on this drug. They're not going to need dialysis potentially ever, right? So we have to be a little bit, we have to discriminate who we're going to use this drug on. So who should we treat with Tovapton? So we should consider this drug in those with a high risk of end-stage renal failure. So we could use that Mayo classification or some of the other scores, but ultimately Australia make this really easy because there's PBS criteria. So the PBS say that the eGFR should be between 30 and 89 mils per minute at initiation, and they must have rapidly progressive disease, meaning they have a drop in their GFR by more than 5 mils per minute in 1 year, or on average, they're dropping their GFR by 2.5 mils per minute per year in a 5-year period. So that was everything I could possibly think of about AD-PKD for your written exams. I hope that helped your studies, and remember to click that link below so that we can send you an incredible one-page summary diagram with everything I've just said for the revision win. And of course, if you have enjoyed today's tutorial, then you will love the live teaching series as part of our deluxe membership. You can check that out over on our website. Thank you so much for joining me, and I'll see you again soon for some more high yield learning. Bye!